Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts. We are truly honored to be joined by a distinguished guest, Dr. David Marti-Aguado, a renowned hepatologist from the Clinic University Hospital of Valencia, Spain. Today, our focus zeroes in on his profound insights into alcohol-associated liver disease, particularly his groundbreaking work on alcohol-associated hepatitis. Without further ado, let's extend a warm welcome to Dr. David Marti-Aguado.
Hello, I'm Dr. Margaret Ting from the National University Health System of Singapore, and I have with me today Dr. David Marti-Aguado from the Clinic University Hospital Biomedical Research Institute in Clever from Valencia, Spain. And he has recently authored a paper that was published in eClinical Medicine in June 2023, titled The Prevalence and Clinical Impact of Alcohol Withdrawal Syndrome in Alcohol-Associated Hepatitis and the Potential Role of Prophylaxis, a multinational retrospective cohort study. So thank you, David, for joining us today to discuss more about this interesting topic. Just to kind of set the background and the tone for the paper, I would like to just ask you, how common would alcohol-associated hepatitis be in where you practice?
Thanks for all, Margaret, and nice to meet you. Really pleased to be here. Thanks to Liver Foundation for the opportunity for this podcast, this discussion about our last paper of alcohol withdrawal syndrome. So regarding your first question, I believe that in tertiary hospitals, where we usually carry our clinical practice and management of alcohol-related liver disease patients, I'm pretty sure that every month we see at least 3 to 4 patients that are hospitalized due to an alcohol-associated hepatitis. This means that the prevalence is high, and we are facing a dramatic increase also, and this has been recently so in international congress like EASL and ASLD, that due to COVID restrictions and lockdowns, the consumption of alcohol has dramatically risen, and the 3 to 4 patients that we were usually seeing per month in our hospitals that were hospitalized due to alcohol-associated hepatitis, this has been increased in the last months, probably, although causability is difficult to robustly establish in this setting, but probably due to the lockdown. And we are facing a new paradigm in pathology that we must be prepared as clinicians to manage this patient as well as possible.
So how common is alcohol withdrawal syndrome in this group of patients, and how should we go about diagnosing this withdrawal syndrome in these patients?
So before our paper, we didn't know what was the real prevalence of alcohol withdrawal syndrome in liver disease patients, mainly in alcohol-associated hepatitis patients that are the cornerstone of what we are talking about. We knew what was the prevalence in non-liver disease patients that had alcohol-dependent patients. This was a systematic review done in 2018 in JAMA journal, and the prevalence was around 10%. Around 10% of the patients that had excessive alcohol use, but non-liver disease patients, during their hospital admission stay, they had 10% of them had symptoms of alcohol withdrawal. But we didn't know what was the real prevalence in our population of the liver box, of the alcohol-associated hepatitis. We didn't know that, but we know a clinical condition, and this is a clinical judgment that was raised during the rounds, then during fellowships we do with our mentors or whatever. And what we know is that patients with alcohol-associated hepatitis that are hospitalized, their course of hospitalization can dramatically change in one moment. And suddenly, due to this alcohol withdrawal syndrome, the problem gets out of the liver box, and dramatically they can get altered mental status, aspiration, infection, intubation, ICU admission. And in a sudden, the big picture has changed, and also the prognosis of the patient. And this was a bit the reason why we decided to take the first steps in the direction of what our paper showed.
So great points. And it sounds like you have had a lot of patients. You've mentioned that you had met a lot of patients who have this alcohol withdrawal syndrome, and this is more of a clinical diagnosis. And can I just ask, what would the current clinical practice be in terms of alcohol withdrawal syndrome prophylaxis? I think in my institution, generally for patients who have any form of alcoholic liver disease or any form of chronic alcoholism, we do tend to give oral benzodiazepines for alcohol withdrawal syndrome prophylaxis. But it seems like the practice is not commonplace elsewhere. So I'd just like to ask, what would you see in your practice, and how would you normally advise your team members or your fellow hepatology consultants in terms of what would you give for alcohol withdrawal syndrome prophylaxis?
Well, thanks, Margaret. I believe this is a great question, and it was the question why all this history started moving now. So I come from Spain, and in Europe, mainly in Spain and Germany, but also in other countries, we are managing our patients in an approach that is based on universal prophylaxis of alcohol withdrawal syndrome in patients with alcohol-associated hepatitis that are hospitalized. And once they are hospitalized and they have the universal prophylactic pharmacotherapeutic, it is clinical judgment that is driven the decision in a clinical decision manner to start benzodiazepine sedatives, in which dose and in which routes. No? And this is what I've done during my career and during my nowadays practice. When I went to the United States for my predoctoral fellowship, what I saw with my mentor, with Dr. Ramon Bataller, the mentor of the paper, and also with the co-first author of the paper, that is Amir Gogol, we were rounding, and with these clinical cases, we saw that the management was really heterogeneous between United States and Europe. And there in the United States, they didn't give prophylaxis for alcohol withdrawal syndrome. And once the patient was hospitalized, it was more like a symptom trigger approach, in which the decision to start sedative was to control alcohol withdrawal syndrome or symptoms, was guided on assessment scales. And the clear example of these assessment scales is the CIWA, that is the Clinical Institute Alcohol Withdrawal Assessment. And these disparities of management is also reflected in the Liver Society's guidelines. And you have the ASLD guideline, and you have also the ASLD guideline where the mentioning of alcohol withdrawal syndrome is scarce. And the protocols are really, there are great disparities between one and another liver societies. And in some countries, we give clometrazole. In other countries, like in Singapore, you start with benzodiazepine. I think there's a lot of heterogeneity in protocols that what are reflecting is just lack of clinical studies, lack of evidence. And we should start with this type of studies and follow up with prospective ones to gain evidence on what is the correct way to manage our patients.
Thanks, David. That's a great point on the heterogeneity in clinical practice. So maybe we can just discuss what were the methods of your study? How did you design the study?
So with the clinical questions that we were asking and we were facing in our day-to-day and during my stay in United States, we started designing the paper. And we know this was going to be the first study in medical literature about alcohol withdrawal syndrome in liver disease patients and in alcohol-associated hepatitis. So to wrap up information in a quick way, it was not possible to do a prospective study. So the first decision, and this is important because it carries methodological issues, is that we performed a retrospective study. The retrospective study was possibly done because we have close contacts in Spain, where I come from, and in UPMC and the University of Pittsburgh Medical Center, where I was in United States, they had a good registry that was led by Dr. Bataller of all the patients with alcohol-associated hepatitis. So with clinicians that were really, that had a good formation in the management of these patients, we start grabbing the information from the medical electronic health records. And what we did was just define the outcomes that were going to be evaluated in the most robust way, just with definitions of clinical practice guidelines. And it must be said that due to the retrospective design and due to the large amount of confounding factors that are in our patients with alcohol-associated hepatitis, we needed the help of statisticians to do this multiple and multimodal, multi-adjusted, multi-weighted, multivariable analysis, just for attending to all the confounding variables that take place in our patients. And try to be as strict as possible in our conclusions. And methodologically, our paper, the aims were just to establish the prevalence and the clinical manifestations and management of alcohol withdrawal syndrome in our patients, and if this condition impacts the clinical course of patients that are hospitalized. And to do so, we evaluate just as one cohort, all patients from United States and Europe, to see if the condition of alcohol withdrawal syndrome impacts any outcome. And for the management of alcohol withdrawal syndrome, because we wanted to see how patients were managed, in which way, in which differences, and if these different management or approach had any impact in the disease. We compared patients from United States that were managed in the way we've previously mentioned versus patients from Europe that were managed in the other hand, in the other way that we were mentioning with the prophylaxis with clometrazole. And this was the highest methodological points that we were discussing and we faced before starting the study.
So I think that's a great segue into discussion of the results of the study. I think, David, you mentioned that you were looking mainly at the differences in management and how that impacted the clinical outcomes. So maybe you can give us a brief summary of the results of this study with regards to the overall management and how that in fact affected the clinical outcomes in these patients.
Okay, so first of all, the prevalence of alcohol withdrawal syndrome in patients with alcohol-associated hepatitis was of 32%. This means that 1/3 of the patients that are hospitalized due to alcohol-associated hepatitis have symptoms related to alcohol dependence, and this is a much higher prevalence than the 10% prevalence we were talking about at the beginning of the interview in non-liver disease patients. And this is important because maybe what we are facing with our patients in which there is a high grade of systemic inflammation is that maybe this could be something that is triggering also altered brain mental status and alcohol withdrawal syndrome that we must at least consider or have in our brain, just to later face where the other findings of the study. In a second point, the clinical characteristics of our patient, this is also really important, because a patient who developed alcohol withdrawal syndrome were not sicker from a liver dysfunction point of view. These patients, even if they developed or not alcohol withdrawal syndrome, the MELD score was really similar. The rate of severe alcoholic hepatitis that was defined with a MELD score higher than 20 was really similar between cohorts of developing or not alcohol withdrawal syndrome. And also the 10% of the population that had liver biopsy and that they had a definite diagnosis of alcohol-associated hepatitis, not a probable, but a definite diagnosis, the histological features of liver disease severity were very similar between patients that were developing and that were not developing alcohol withdrawal syndrome. So this is a very important point because it keeps on mounting evidence that it is maybe more what is happening outside the liver box and this high grade of systemic inflammation that could play a role in the developing of the alcohol withdrawal syndrome more than the seeker that our patient. And it is important because in hepatology, paradigms are really nowadays changing with NAFLD, but also with ALD. And we have to take a step further and open our minds to manage our patient, not from just the liver perspective, but also from the systemic perspective. No? This was the second point. There's a third point that it's really important, that is the management strategies, no, and the disparities that we're seeing between cohorts in United States and Europe. So we compared them, and we saw like three main results regarding the management strategies that must be highlighted, and I think that the readers of the paper, they should encourage them maybe to even change the clinical practice that they are performing. So first of all, the dosing of the sedatives or benzodiazepines, of hypnotics, that we give to treat the symptoms of alcohol withdrawal, if they are driven or they are guided by the assessment scales, and we were talking previously of the CIWA, and the CIWA was developed in non-liver disease patients and not in liver disease patients. Well, if we carry this approach, we are inappropriately giving much more dose of benzodiazepines and in a route that is IV route instead of oral route than probably we should. And this is counterintuitive because we know that sedatives mainly have hepatic metabolism and this can carry hepatic encephalopathy and worse prognosis of the hospitalization outcomes. So what we believe is, again, going back to the systemic inflammation, maybe we are overestimating with these scales what our patients should receive as treatment, as sedative treatments, and we are just pushing our patients to maybe a higher rate of altered mental status, aspiration, infection, intubation, ICU admission, and all these pathway that we don't want to go, no? In a second point in the management, we saw that IV benzodiazepines and also phenobarbital, that is a potential sedative, these patients that received these sedatives were associated with higher mortality, even though the model was adjusted by many confounding variables. And this is also an important point. What we are trying to say to our friends, to our hepatologists, is be very cautious with this patient, close monitoring, because alcohol withdrawal syndrome starts the first day, maybe the second day, but not more. So it is the first 1-2 days of hospitalization that we have to be really close to our patients, taking care of them. And if they start with minimum symptoms, be quick with oral benzodiazepines, maybe if we start with that treatment, instead of over utilization of other type of sedatives, other routes, and other drug doses. And finally, what we saw is that prophylaxis with clometazole was associated with lower cases of withdrawal syndrome. It was associated also with a less severe withdrawal syndrome once it was developed, and with better outcomes during the hospitalization. And finally, if we get all the patients, the pool cohort, and we just saw if the condition of alcohol withdrawal syndrome was associated with a poor outcome during the hospitalization, we saw a striking result that must encourage us to be very aware of these patients that develop alcohol withdrawal syndrome, independent of ACLF, infection, steroids, treatment, and hepatic encephalopathy, the MEL score, the age and sex, and all these confounding variables, these patients have higher mortality. And we believe that it is the pathway, because we saw that these patients had higher infection, higher ICU admission, higher hospitalization stay, and we believe it is the typical pathway that we were seeing with the clinical cases of altered mental status, aspiration, infection, intubation, ICU, that are driven our patients to a higher mortality, and that we must be very cautious that in the first 2 days our patients don't get that pathway, and we are taking them through another pathway with better outcomes.
Great. These are all really great points. I would just like to ask, going back to the first finding that you mentioned that there's a changing paradigm where systemic inflammation seems to be a driver of the development of alcohol withdrawal syndrome and subsequently poorer clinical outcomes. I think in your paper as well, you mentioned some predictors for the development of alcohol withdrawal syndrome. Did you study any of the factors, like are there any biomarkers of systemic inflammation or any new research on the horizon on such biomarkers that could predict the development of alcohol withdrawal syndrome?
So thanks for the question. This is absolutely a great question. Our hypothesis is that systemic inflammation must be behind what we are seeing, no? When we compare patients that were developing and that were not developing alcohol withdrawal syndrome, what we saw is that patients that previously had a withdrawal syndrome had a higher rate of new onset of alcohol withdrawal syndrome and symptoms, and also that patients with lower platelets had a higher rate of withdrawal syndrome. And we believe that lower platelets are more related to alcohol abuse than a late stage of cirrhosis with portal hypertension or with whatever, because we didn't have many patients with cirrhosis, and also because it is known that alcohol consumption, chronic alcohol consumption, lowers thrombopoiesis, has low folic acid, and this is related to lower platelet levels. No? So that is what we found. It is true that simple markers like PC, like protein C reactive, was not evaluated in our paper, and this is a simple blood test that I should encourage prospective study to look at it, because it has been shown its potential use in ACLF, and maybe we are seeing a short type like ACLF. And more specific markers were not seen by in our paper, because it was retrospective and we couldn't go through that way. But with the evidence that was found, for sure, we are now beginning a new study design where these markers of systemic inflammation must be seen, and also not only the markers, but also what. The levels of alcohol in blood. This is also important, because we wanted also to see the last day of drink before patients arrived to the emergency department. This was not possible due to a retrospective design. But we do believe that the alcohol markers, like maybe PEth, for example, that is really a hot topic now, can reinforce the systemic component of this pathology and give some insights in what is the real state of the systemic inflammation that we are seeing in the patients that developed withdrawal syndrome.
That's a actually great answer, and I just want to kind of zoom in on something else that you mentioned earlier, where you mentioned that the IV benzodiazepines, and in these patients they tend to get a higher dose of benzodiazepines, and they have poorer outcomes. So I just wanted to ask, in these patients with alcohol withdrawal syndrome, how would one differentiate between alcohol withdrawal syndrome, or how would the use of benzodiazepines confound the assessment of the patient's mental state? Is there any overlap with hepatic encephalopathy?
Great question, Margaret. So, and this was a great debate with reviewers in the journal. So maybe you were one of the reviewers, and just joking. This is a great question. So first of all, to start with the answer, just mentioned that patients that with alcohol withdrawal syndrome and alcohol-associated hepatitis received a much higher dose of benzodiazepines in our study than compared to other studies that evaluated withdrawal syndrome in non-liver disease patients. And this is really important, because I go again through the same message that this can be counterintuitive, no? Because our patients are really sick of the liver, and we know there's a liver metabolism of the sedative therapeutics, and this was really a striking result in the first part, no? Secondly, for sure that it is conceivable now that patients with severe alcoholic hepatitis that develop withdrawal syndrome and that receive IV benzos, after the administration, they can have some degree of concomitant hepatic encephalopathy that can worsen the disease course and the prognosis of our patient. That for sure. And it is difficult nowadays to differentiate this brain liver these brain diseases that we are seeing in our patients, because we don't have specific markers. There is a great review in gastroenterology by Jas Bashas, and we really take this review to define if a patient was having alcohol withdrawal syndrome or hepatic encephalopathy. And the differences can be based on symptoms, because it is difficult for hepatic encephalopathy to have or tremor, hallucinations, or confabulation. They have mainly asterixis, flapping, insomnia. And fortunately, we had levels of ammonia also. We know that ammonia is not a perfect biomarker. We know the limitations of ammonia, but recently EASL guidelines are telling us that normal levels of ammonia exclude hepatic encephalopathy. So we relied in these ammonia levels, and what we saw is that ammonia levels really correlated well with hepatic encephalopathy grade, but not with the SIWA scale. It correlated well with the scales of hepatic encephalopathy, but not with the scales of alcohol withdrawal syndrome. This was an important point. And also in patients that had alcohol withdrawal syndrome, those who have concurrent hepatic encephalopathy had higher levels of ammonia than those who didn't have hepatic encephalopathy. So although this was not statistically significant, we can clearly see differences in values. And what they are telling us, in our opinion, is that these two conditions are really difficult to defer, especially when we are adding sedatives as treatments. But as a clear and close and practical recommendation, symptoms can be different, and mainly alcohol withdrawal syndrome have more psychological agitation, and hepatic encephalopathy no. Also, the onset of symptoms are really different, and if one patient, I really insist in this point, patients that develop withdrawal syndrome are developing the symptoms in at a higher point in the second day, not more. And hepatic encephalopathy can come much later. And also, if you have ammonia levels, you can just add this piece of information to your decision making. But for sure that we were talking previously of specific markers of systemic inflammation, specific markers also of types of brain disease should also be further assessed to play a role in the management of our patients.
Okay, I think these are really, really good points, and I think that's really clarified a lot of the controversy or debate on certain points in this study. Okay, David, so I think just like to ask you about your personal practice or any clinical pearls that you'd like to share with our listeners. It sounds like in view of the results of this study, alcohol withdrawal syndrome prophylaxis actually should be recommended for all patients with alcoholic-associated hepatitis. So personally, what type of medication would you use, or what dose would you give, and how will you monitor these patients after starting them on prophylaxis?
Okay, so this is a great question, just to end up with a practical point of view. No, in my case, what I do at my hospital is we have a protocol with universal prophylaxis. So all patients with alcohol-associated hepatitis that get hospitalized receive prophylaxis for withdrawal symptoms. And this prophylaxis in my hospital is done with clometiazole. That is a sedative derived from thiamine, and it enhances the GABA action, but it's not a benzodiazepine. And what the dose that we are giving in clometrazole is the actual dose is 315 milligrams, and we give the 315 milligrams 3 times per day, 2 to 3 times per day. Okay. I know that there are some countries that do not have clometrazole, and in other parts of the world, and I've seen other colleagues performing this practice that they've used benzodiazepine as sedative for prophylaxis. Maybe I will go for a clorazepate as first option, and this is 25 milligrams per day. And I think this is a good option for prophylaxis of the withdrawal symptoms. If you are not used to clorazepate, if you do the diazepam equivalent format, is like 10 milligrams of diazepam per day. Okay, this will be in the prophylaxis protocol that I will that I clearly defend, and because it's my daily practice, and after also the evidence that raised up with the work, with the paper. After prophylaxis, what we do, and this is in the protocol, is that fellows that are with the clinical rounds, these patients are have like a red alarm, let's call it that way, and should be monitored every 4 hours. Every 4 hours. It can be monitored, a close monitoring. It can also be done with whatever new things happen. But every 4 hours, the patient must be seen, because slight changes of agitation or even the patient can tell you that they are having the withdrawal syndrome. Should be recorded, should be evaluated, and we should anticipate with a low dose of benzodiazepine, and it should be oral. And if we give diazepam, it should be at 10 milligrams. Okay, and in case we are facing the worst spectrum of the disease with a severe alcohol withdrawal syndrome and difficult to manage, for sure, this should be a multidisciplinary management, and ICU colleagues should be also advised that we are or considering the patient with us, and we have now some criteria for that the patient get admitted to ICU only for the management of withdrawal syndrome. And I think that is taking another step, just to not face the problem when the problem is difficult to solve. That is the aspiration, intubation, and worse hospitalization course.
Thanks a lot for sharing these great clinical points that I'm sure a lot of us can adopt in our daily practice. I think just to wrap up this discussion, I'd just like to ask, in terms of your thoughts regarding future directions in terms of research in this area.
So future direction are, number one, clinical trial, randomized clinical trial to evaluate the role of prophylaxis in the development of withdrawal symptoms, the severity of withdrawal syndrome, and the outcomes of patients hospitalized due to alcohol-associated hepatitis, number one. Number two, prospective studies to confirm what the first study in the field of liver disease patients and alcohol withdrawal syndrome has seen. And finally, specific studies with much more fine parameters about brain disease and about systemic inflammation, that most probably is the actor that is behind what we are seeing, to better characterize and typify our patients in order for risk stratification and to imply different management strategies depending on the type of patient that we are facing at the time of admission.
Okay, thanks a lot, David, for your time in discussing this article. And thank you for joining us on this podcast by the Liver Foundation. Thank you.
Okay, thank you very much.
Thank you.
We have come to the end of the episode. Thank you for joining us and stay tuned for more captivating discussions.